The work that we do at WINRS is kind of twofold. The first is that our team serve as consultants to research teams on specific projects where community and patient voice is central to their work. Next slide, please. This is the description of our team. We work at the intersection of health, equity, and community to facilitate the contribution of patient and community voice in research, and specifically with a focus on amplifying voices from historically and persistently underrepresented communities. We do this because we know there's a bit of a gap between academic knowledge and lived experience, and we're trying to shrink that gap to bring about a more socially just world. Next slide. I mentioned that we serve as consultants for projects that are specific to an individual researcher. So I'm just sharing 3 projects we're working on right now. This is Mai Chu Lor in the middle from the School of Nursing. And she's working with Hmong students who are helping to create a culturally sensitive manual for end of life that is a collaborative project with Extension, who developed this manual for native English speakers and people who have grown up in this country, and wanted to make sure that for people who have come from other countries in particular who speak Hmong would also find value in the manual. Next slide. This is a team led by Megan Piper that is looking at co-creating a smoking cessation program that's relevant for the African American community. And they've gotten a group of people in Milwaukee together to design and give input on what might be appropriate as smoking cessation policies and practices for their community. Next slide. And then a third project we're currently working on is with Anupama Joseph. She's a cardiologist here at UW. She's been working with the Forest County Potawatomi at a clinic in northern Wisconsin for a number of years. And she determined that developing a cardiac health initiative would require elders and people who are experienced cardiac issues in the Potawatomi tribe to shape that and to create together a clinical practice that would transform the health of their tribal members. So we go up north, it's about a 4-hour drive, and we have 2-hour meetings every other month. So that's a really amazing collaboration. Next slide. The twofold way that we bring lived experience to research teams is through that collaborative lens, but also these 2 incredible groups that are standing advisory groups. And a drum roll for a moment here. They have been in existence for 14 years. We're celebrating 14 years. And in both the groups, there are members that have been on the boards for all 14 years. So they are incredibly close-knit, and they are really, really adept at listening to researchers talk about their projects, share their materials, and then give constructive feedback that can strengthen their work. Next slide. I share this. Many of you have seen this type of a spectrum before. The initial spectrum came from Sherry Arnstein in 1969. She developed the spectrum of public participation, and this is a version that the International Association of Public Participation has revised. The idea is that the level of engagement shifts from very minimal, where the communication is really one direction. Here, we're sharing with you this information in a website, or we're handing you this flyer. It's very unidirectional in this learn, inform blue side. But as you move towards the green, what you're doing is bidirectional. You want to hear and learn, and it becomes iterative. And then as you move towards the green, you're actually shifting power from a research team or group leading the project to being a part of a team that's collaboratively doing the project and is led by community members or patients, and their perspectives drive the work. Next slide. Here's kind of a visual image. I'm a visual person, so I like this one. What it shows is that top banner couldn't be more accurate. The degree of difficulty with moving up the spectrum towards more community-led is increases the more power is shared, distributed, or shifted, and the impact often increases as well. So there's good reason to work to incorporate community voice. But as you see, the sort of ball, the little white ball, if it represents the research team, first is just sending out information, then is listening, then is going back and forth iteratively of listening and revising and returning and listening and revising. And then ultimately in the red at the end, there is no central ball of control. It's all shared and dispersed control over the project. Next slide. Language that's common these days, and I assume it came from engineering folks, but is about co-creation and the idea that rather than drafting something and having somebody revise it, you're all together in the process of creating something. And so these words are representing the very same concept that was just showed in other forms, but it really is about moving up to co-designing and co-producing. And the benefits, I think for this group, don't need to say too much about how important it can be early, often, to get that input to strengthen the reach and relevance of work that's being done. Next slide, please. Many of us here are translational scientists, and so the compelling finding that there's an average of 17 years to get from bench out into practice is really one of the reasons why NIH is starting to talk about the importance of community voice. Many funders are, but that these translational bits can really speed both the time in which it takes to get important findings into practice, but also the reach, that it doesn't only apply to some, but that it actually reaches groups that have been traditionally marginalized. Next slide, please. I love this description, and I'm just going to be quiet for a moment as you read it. So really the idea that equity designers should really be the people who are experiencing the issues. Equity allies are those peoples with resources and expertise and strength and vision to support them, but that without their voice, we're missing the key ingredient of making sure that it's relevant and has the important reach it needs. I want to give a shout out to Jennifer Edguse, who was a part of this commission that developed this work. Next slide. Just a dazzling image from the National Academy of Medicine, just to point out that they are, in theory, centering community voice. You see the green there is about community engagement and lists co-principles of working with community, and then talks about how health equity occurs through transforming systems for health. So not just me speaking what I think to be true, but certainly important acknowledgement across the field about the central nature of this perspective. Next slide, please. I also want to point out, since we are at a DRISS seminar, that this cycle, the research cycle, and I love this slide because it's British, because you see the word prioritization with an S. But the research cycle has these early identifying the priorities and honing in on the research questions, all the way through conducting the research and then disseminating and implementing. And what I have seen in the time I've been working in community engaged research is that it's more common for people to come in to get perspectives from patients and community at the point at which they have a project fairly fully designed. They've maybe gotten funding and are struggling possibly with recruitment. And so they want a perspective about what could be going wrong here. Tell me about the compensation and the recruitment materials. How can we fix this? And that, of course, is kind of in the lower half of that circle. But what we're strongly encouraging is for people to think about the early and the late side of this cycle. So the early being before you've gotten the grant, talking to people about their priorities and your ideas and having the actual proposal be shaped by that feedback very early in the cycle. The catch is that we ask people to be paid and people don't have funding before they have the grant. So finding ways to make that work is sometimes challenging, but pushing it to an earlier conversation is incredibly exciting when you see the kinds of energy that happens when researchers allow their questions to be shaped by those who are most closely experiencing the issues. And then on the D&I side, people often miss the opportunity to have community voice really strengthen the dissemination and implementation of the work. Where should this go? Who else needs to be hearing about this and doing this and incorporating this? So just a shout out to considering all parts of this cycle as relevant for community voice and input. Next slide. So cards, Shanice can attest to this, have spoken to research teams, now hundreds of research teams over 14 years, about ideas and projects at all the different stages. So about topic selection, research prioritization, looking at increasing access to breast cancer, how might we shape the questions we're asking about this, designing and conducting the research, and then dissemination and implementation. They talked about a brochure on emergency use of naloxone. We talked about this program on end-of-life planning and a phone app. We've worked quite a bit with Sarah Davis and her group at the Center for Patient Partnerships on apps that serve community people and how to promote them and make them accessible. All right, the last slide for my part of the conversation is here. I'm going to turn it over to Shannon. What I think is an interesting point that she'll hopefully highlight today is that when we talk about community voice, one of the things that immediately comes to people's minds are people in positions of power in community. So people who are leaders of community organizations, nonprofits, people who are pastors, people who have a voice that is listened to, and they are surrounded by community and working in community. And that is a really important perspective. And it's not the only perspective. The other people that have wonderful input and can offer unique insights are those who are living their lives in neighborhoods and may not have positional power. Maybe people who are using services, services like the food banks at community centers, childcare programs, but those who may in fact be closest to the very issues that are being studied. And so in the project Shannon's going to talk about, she'll mention the layers of talking to people who are in those positional power, professional roles, and those who are in community member roles. Thanks so much, Shannon.
Great. Thank you so much, Kat, for that introduction to the project that a small team of us were able to do along with the Great Cards membership. And I, of course, must start with a tremendous appreciation to the Cards team and also to Shanice Taylor, who's here today. And we had such a meaningful, delightful, informed conversation that was totally off the academic script that we normally do, and just had so much value. And I know you want to get to hearing from Shanice, because I'm sure there will be some great learning again today. Also, I want to thank Jane Mahoney and the D&I team, because a few years ago when WashU came, I said, hey, how do we know that we're having impact in areas of health equity? And WashU had designed this brilliant model called the Translational Science Benefits Model. And they said, well, we're working on that now. And I said, well, we can help you. Wisconsin can help you. And it was Jane Mahoney. When I went to her and said, you know, we really need to get some community voices on this, she said, we got that. You just tell them when they're ready to make this happen, we are here. And so then when the time came for us to be able to do this, so grateful to be able to work with CARDS and also to approach ICTR. So I have appreciation too for ICTR, which was able, through the protocol development program, which is a relatively new program, but was able to provide us a grant to be able to do this particular work. So again, I'm presenting the Translational Science Benefits Model, and thanks to Kat for inviting Shanice and me to co-present. Okay, next slide, please. So the history of this model, and probably many of you have seen it, in the beginning, when scientists, researchers were reporting their impact, it basically came down to academic outcomes like publications and grants. But over time, we've gotten much more sophisticated and been challenged by our funders to be able to identify what policymakers, communities, what patients, what they really need and really care about. And so we're getting better at doing that. And then also pushing more and more to be able to assess the impact. So once we know we can reduce the incidence of disease, or we can provide programs to folks in diverse settings, we can do better things to be able to make our research findings more accessible to all. What meaning does that have? So how do we know that we've actually made benefits across people's lives? And one of the things that came out of the CARDS meeting that was so impactful to me was an understanding of, really, it's the role of research to decrease human suffering. And we all go into medicine knowing that that's true, or into research knowing that's true, but also to really sit with that about how really it's our obligation to decrease human suffering, and human suffering for everybody. That is just a very powerful notion. And so next slide, please. So a handful of folks then created this Translational Science Benefits Model at the request of researchers who said, how do we know we're having an impact? And they then classified and categorized using evidence-based models and different forms of interviewing and protocols to be able to identify what are research findings that are most important for demonstrating the impact of science across communities, and in particular, outcomes that are important for community members, for policymakers, and for organizations who create change. Next slide, please. So maybe you've seen this, maybe not. It's your basic logic model that starts at the left with, what are the resources that we bring to the table to be able to do this research, and ends with impact on the right. So let me walk you through that quickly. We get resources, funding, money, people, the literature, previous research, deans, we get all kinds of resources from various corners, and we engage in scientific activity. That, research studies, focus groups, as it is. And then that scientific activity is translated into some levels of outputs or outcomes. And those are the things often where historically academic prowess, academic performance reviews stopped in that, what are the scientific outputs and outcomes? And so now the team at WashU have brought this model nationwide to multiple medical centers, multiple institutes across the country to say, yes, but where is the benefit? Through dissemination and implementation, what actual benefits are you seeing in communities? And so they created these 4 domains, which you see the yellow, blue, green, and darker blue, of where are you having clinical benefits, where are you having community benefits, where are you having economic benefits, and where are you having policy benefits? And the bulk of this was created then in an ivory tower which is getting less ivory tower now, but still in major medical centers and universities. And so it had predominantly that lens. And so WashU, they knew that they were being pushed, including from people like me who said, right, but where's the health equity impact in this? Next slide, please. And so we were looking then to determine which benefits, where within these 4 benefits of clinical, community, economic, or policy can we actually perceive health equity benefits, and do we need a new benefit, a new bubble, as it were? But the decision was made to embed then the health equity benefits across these 4 domains. Next slide. And so here's some of the examples of existing benefits, things like better diagnostics, reducing the cost or burdens of illness, making care more accessible, changing policies like, who can use what kind of medications, et cetera, supporting laws that help to keep people safe. These are some of the basic benefits that were existing previously in the model. And so our goal then was to integrate health equity benefits. Next. One more. So I can show you some examples then where, one more slide, please, where we can see these. Pull up all of these for me, please. Thank you. You can see then where these different projects that were happening that had multiple different kinds of populations or samples of interest to improve access, for example, blood cancer or telehealth for vets, that these have been identified as exemplifying the benefits. The clinical you see in the yellow, the economic in the green, the community in the blue. So we have lots of great examples of these benefits, but we want to be able to get better at identifying specifically what are the health equity benefits. Next slide. And so, obviously we are not targeting equality. Many of you have seen this, I'm sure, but we are talking about equity. And how do we, as researchers who don't always live in these spaces and places, and mostly probably don't live in spaces and places where access is limited, where supports are few or fewer, how do we then strive to reach equity? And we really need to understand then from the experience of folks who live with the healthcare systems and policy systems that we are responsible for establishing. Next slide. So in order to help people attain their maximum benefits of health, we had to think about how would we know if we were having an impact. So the first step in thinking about health equity benefits, which Kat alluded to, was going to community organizers, going to directors of community agencies and organizations. And this happened in St. Louis, to say, what are the things that would be most impactful for the communities that you serve, for the groups of folks with whom you work? And so we had people who were in housing organizations, in child and adolescent development organizations, nonprofits, federal programs. And those folks then help us to identify some of the health equity benefits then across these 4 domains. So things like community, reducing delays in getting to the doctor was critically important. You can't wait 6 months if you're sick. Or like clinical, improving diagnoses for all, no matter what language that someone speaks, making sure that we can get accurate diagnoses regardless of the language in which the doctor and patient, or multiple languages in which they're communicating. So the community organizers then help to identify this first an additional set of health equity benefits. Next, please. And so when we approached CARDS and worked with a group, which was there was probably 15 of us on the call, and we asked them what specific benefits are absolutely essential to you from health research or healthcare, and how do you know that the impacts have been evenly distributed so that all people benefit from the research? And I will tell you that this was, as Kat is mentioning, this is so critically important because it was a perspective that researchers who are all going to benefit and use this model all the time didn't have that perspective. And it's really poignant then when someone using their own voices, their own experience gets to talk for themselves or for the people that they know and care about. And it brings real meaning then when we're with the people in relationship, it brings real meaning to the work that we're doing. It's not cognitive in an ivory tower in protected settings. It's real. And that as a researcher is just so incredibly impactful because this is what really matters. The rest of it critically important. We couldn't do without it. But as one of the participants said in that meeting, said, you know, these health equity benefits don't really matter if we don't have trusting relationships. If the researchers are not trustworthy, then getting to the health equity benefits doesn't really matter. So it really it gives you a whole new perspective on how to better understand the work that we do. And we're all in this work to decrease human suffering. And so we have to evaluate for ourselves, have we hit that mark? And if not, then we are all invested and engaged enough to do what we need to do to hit the mark. Shanice, I'm hoping that you will next share some of your thoughts and on the group. Next slide, please. May I pass it to you, or Kat, maybe?
Yes, I can take it from here. So thank you, everyone. And thank you so much to Kat and Shannon for the work that you do, which is, as you said already, extremely important. And I think it's even more meaningful to know that you are going out of your way to put yourselves into the shoes and the eyes of the community that we are all directly serving in one way or another. So I will touch on a few of these points, but you can also read as you go. So with the positive personal experiences, this is just having positive experiences to continue to encourage essentially like community members and those who are receiving healthcare to feel good about the care that they are receiving. And one of the biggest things I commented on or recognized was education. Sometimes it's literally being able to know what you don't know. And I think a lot of it is just not having the information accessible to you to even know if it would apply to you or if it may apply to someone else. So the educational piece here is, like I said, important, not just when it comes to knowing like simply terms or like even conditions specifically, but also education in terms of like knowing how to treat those or treat specific things and even having more access to resources from being educated on that. Going down to the negative personal experiences part, non-disclosure, specific findings. So this kind of ties in also with the skipping down to more the lack of transparency and relatability. It's really important for community members to have like full transparency or wanting to know very clear cut what's happening. I think it's just in general a good rule of thumb to have integrity about it so that you can know how to move forward. I think there have been times where a lot of people of color have been in spaces where even like people really don't know. And I think no one ever wants to acknowledge like that they don't know something or don't know what to do in the healthcare space. So I think this is really important, is just to be very honest and have integrity. And then going down to the historical trauma part and the lack of trust. And I would even touch on like lack of healthcare accountability with specific groups not feeling seen or heard. I often hear about Black women feeling like their pain is like invisible or like they can endure more pain than others. And I've even had like my own personal experiences where I've been in spaces and I'm expressing that I'm having concern for something. And it's just kind of like brushed off, or I would even say like minimized to an extent. And I don't think anyone would minimize feeling pain or being in distress. So I think this is really important with touching on negative personal experiences, is that community members need to be fully seen, fully heard. And I think that is a way to be accountable. And then I did want to comment also on the relatability part and transparency. So a lot of language that is used is I understand for like medical purposes, but it's a far disconnect from like what the community is receiving and what the community knows. And that also goes to the education piece. So a big thing with transparency is making language very clear, very easily understandable, so that it feels that everyone is all on the same page and has a clear understanding of things that are taking place when it comes to healthcare and access to it. And then even relatability as well. I think it's important to see like people of color in those spaces that they that who they're being served by. It's very assuring to see people of color, but not just people of color, but also others with lived experience. So even for themselves, if they've had lived experience of themselves being able to experience symptoms or treatments of specific healthcare needs, and not just that, but also just knowing how or being in spaces where they've supported others who can do that too. So making choices or getting feedback and treating or supporting communities that you have a direct tie to or a direct experience, given whatever that healthcare need would be. And going down to improving healthcare benefits, it's important for, I said feedback, patient feedback is the biggest one, because like I said, this is how you are able to know if the results are getting across to the community that you're serving. They are able to say like, yes, this is working for us, or no, this is not working for us. And that is a way to make sure that basically like the results are translating in the way that you would want them to. And then I also touched on hearing again from the population that's directly impacted, but given that healthcare and is different from obviously like the community standpoint, healthcare workers and healthcare fields standpoint, community members aren't able to conceptualize like what goes into like maybe research, what goes into framework around healthcare and even access to it. So I think community members really rely on healthcare services to create the framework and structure to be able to implement what their needs are and what their concerns are and voice those as well. And then over to the benefit side, the other thing I wanted to comment on that really stood out was high quality care. So I know that like a lot of places that are serving communities of color specifically are kind of giving to me what feels like bare minimum care, when high quality care should really be accessible to everyone, and especially the most vulnerable population who is not able to have access to it alone. There was something else I wanted to comment on. It was back on the negative personal experiences side, which kind of ties into the benefits. It was the limited access to medical advances. So I also feel like people of color and others who are less fortunate are on the lower end of like receiving access to medical advancements, at least in a way that feels very genuine and not as sketchy, especially given like the historical trauma and also just the history of what has happened in the healthcare industry for people of color when it comes to testing models or trying models. So I think it's very clearly understandable to people of color what feels genuine and what feels like it is something that that has been tried, that seems like it works, that they don't have access to, versus feeling like they're in the shoes or position of being like lab rats, which I think is a big thing, especially given, like I said, the history. But the other thing, yes, medical advancements, I do feel like people of color and other underprivileged communities are the last to have access to. That was all I was going to comment on.
Thank you so much, Janice. You know, I think your final point really gets to an aha moment that one of the researchers from the Washington University team said. He was processing all that was being shared and said, you know, this just means we need to start with the idea that the best we have to offer goes to everyone. Not that the best starts with the few and then slowly trickles out to everyone, but what if we start with everyone must get what we're doing that is the latest and most impactful. So it was fun to see him sort of, this means a lot. Those moments are powerful. So our idea was that we would welcome some Q&A, and I had as the last slide there also inviting people to contact WINRS. We are open as thinking partners, and I say that's kind of our primary job, is when somebody's dabbling into something that may be new, maybe not, they don't have a lot of experience with. What we love to do is just hear about the research ideas and think about how community and patient perspectives might strengthen the work that's being done. And then if there are good places to bring that in, what the best methods for doing it are. So we welcome that. Because of that early part of the cycle where people are unfunded, but they know it's important to get that voice, we can offer 20 hours of free consultation for any research team. So you don't need to have a grant to have the conversations. And we really would love to hear from anyone who's believes in the value of community voice. All right, so I read Shannon's. Please note several of the items our research group would not have gotten to without. Shannon, do you want to just pop in and say what you were thinking there?
Sure. I just wanted to mention that several of these pieces of, thoughts that we would not have gotten had we not met with the cards group. And so that just shows you that, we all have our blind spots. We all have, have the corners into which we don't see. And so we have so much gratitude, and the model will be improved 100% because of that meeting and bringing to the table things that we're like, that are just so critically important. So we wouldn't have gotten that without cards, and we're really, the work, the research is absolutely, and the research then, the other thing, this is going to affect this nationally used model. And so we're really grateful then that we have this information now, and not 3 years from now when somebody says, well, have you run this by anybody? Like, who's actually benefiting? So that's what I wanted to say. Thank you.
It looks like Anand Narayan, who is a frequent flyer with the cards groups, he's come many times, added a nice comment. Can't emphasize how wonderful the cards group is to support more inclusive research and clinical practices. Thank you for doing this session and for all your work. I was wondering if you had any tools for patient communication that you have found to be effective from your discussion with cards groups. I don't have anything off the top of my head other than lots of work is being done on shared decision making and what those materials look like, but they're really kind of specific within a context. So life support context or treatment in breast cancer are topics that have come to cards, and they have really helped to think about the language that's used to incorporate both patient and their families and their caregivers in the decision. So I don't have a quick answer on it. I'm sorry. If somebody else does, can they type it in the chat? And then I guess we are waiting for anything in chat, right? Can people not be heard if they're participating? Is that how this works? Huh?
Right, with the webinar. I do have one question as I'm thinking about the translational science benefits model and this idea. It is a type of logic model where you're starting from the beginning to look at, well, where you're going to get to. I wonder, I just wanted to get your all's thoughts on how can you use that to help incorporate racial equity from the beginning. I feel like, just like you mentioned, Shannon, that well, you don't know your biases. Well, we all sort of have an idea of who this is going to benefit, but it's for all of us, that's an ill-informed idea because it doesn't incorporate perspectives that we don't know. So I wanted to get your thoughts on how we can begin to think proactively to make sure that we are being more inclusive from the beginning.
I think it starts with education, right? So someone even recognizing the limitations of waiting till the end and what that means for the work itself, and how you might have to go back then and start at the beginning if you didn't think about what the end results will be. And this model, then what it provides is the ability to see it from the beginning and recognize that those areas of impact is what you're actually starting, like you start with all of it and map your work to that whole model. And the model's not something then that you come around to at the end of your research. It's something that you start with. And WashU has made, I will find the website and put it in the chat. WashU has made a tremendous toolkit that helps to walk scientists through all of the different stages, the resources, the scientific activities, the scientific outcomes, that helps folks to identify early and often and revisit all the stages of the model at the beginning or all the way throughout the journey. And so we're hoping, and they're hoping, and many people are seeing and experiencing then that having these categories of impact and having indicators that are evidence-driven and kind of higher level that folks can get specific examples and can define for their own utility, that having that at the start, if you've embraced the model from the beginning, and now even with the health equity indicators that weren't explicitly laid out, that with that as a model, folks can have a plan, like it's the research recipe for engaging in their next trajectory. And then obviously consulting with all the folks that you need to consult with in order to be able to build your health equity expertise or even approach. Hopefully that explains. I think the toolkit is really useful, so I encourage people to go visit the toolkit. Let me go find the link.
Shanice, did you have anything you wanted to offer to Jean's question about how do we know that at the beginning of our work early that we will have equitable benefits? Equity will be centered.
I personally think that it really has to do with like the community that you are serving. So of course, I think that when it comes to like research and healthcare, there are like often a select group or a few people who is kind of used as like the model to represent or be representative of everyone and how that would serve everyone, but there's always going to be someone missing in that. So I would say thinking, as you said, like it's easy to think about who is present in the space, but kind of like reshaping your mindset about maybe who is not present in the space or whose voice is not present in the space or heard in the space to continue to make equitable research available. I think that does often though come with putting yourself out there and putting yourselves into those spaces, or like at least offering the opportunity for people who are not in those spaces to be able to feel seen and heard. So that will though require, I feel like if researchers are really committed to seeing that, that change in their space, they will be committed to putting themselves into different spaces to be able to hear different voices. Just because community members often don't know what's happening on the backside or back end, just advertising it, I would say, is a start. And the people will just come out of the woodworks.
Yeah, Jane, I think if every single person in the health sciences could read the paragraph on centering voices, and just with that first sentence, uplifting, trusting, and valuing the lived experiences of the people most impacted by the issues, that if you start there, you won't miss the boat. You'll be looking to make sure that you are listening to the right voices to make the work equitable.
I think that I feel like as anyone is designing a new translational research project, particularly if there's an intervention, but even without, if you're just finding information, it may be helpful to go to the cards early on just to say, what do you see could be the translational benefits? And because again, just to have perspectives that aren't necessarily research perspectives would be very valuable.
I wish Anand could speak, because what he wanted to do was just develop a relationship, in particular with a group of Black women, to talk about mammograms and screenings and what are the barriers and what could we do to limit those barriers. And it was conversational. It wasn't bringing any specific recruitment materials or items. It was just, how can we make this better? It's a real issue. It can save lives. We care. We have some resources. How can we do this? And so he was definitely in the realm of co-creating. He was definitely in the realm of centering voices, and definitely in the early stages, getting that conversation going.
Yeah, we can unmute for Anand if you would like him to speak.
There is a question from Jennifer in the chat.
Yeah, just want to make sure somebody got to that. What sorts of community dissemination tools do you find most effective generally? And also, have you run into the issue of paying community co-researchers affecting their benefits? If so, how have you addressed this?
Okay, so just this week, we were in a session, Leanne was leading, and I think Allie was there too. That was a dissemination implementation work group to talk about a specific project. And I sent attachments and a list of like 8 places that I thought had amazing community engaged D&I resources. So if I send that to this team, they could send that out with the information rather than try to list them all. There are some really, really great places. And Shanice can attest to the fact that the greatest pain point, and I am not kidding when I say pain point, for cards and the team of us at WINRS who work with cards, was trying to balance this $600 limit, where after $600 in a year, it needs to be reported as income. And for a number of people in the groups, that would put at risk incredibly important benefits, including housing benefits, food benefits, other things. And so we have worked to try to find workarounds for that. And any workaround raises the eyebrows of fiscal folks, because it's a problem we haven't solved. And we have cards members who can make up to $600 and then come to meetings without being paid, because they can't have that risk, and we are required by law to report the income. So I speak to you with a heavy heart that I don't have a solution for that.
Any other questions?
I just would like to comment about the critical importance of meeting with people also informally, going to places and spaces where there are, where you can create these relationships, where you get a better understanding of what is the lived experience. So, some of what came out of the cards meeting is things that I've heard in confidential conversations with friends and colleagues, and somehow hearing it in the cards meeting helps me to understand that it's more general than one person's experience. And And the example I'll give that Shanice talked about earlier that's so critically important is being heard when you go to the doctor, and just the amount of time then that people can get sicker, and later illness is not being prevented if people aren't being heard about their symptoms. And so I think we increase our awareness then also when we put ourselves in spaces that we don't experience maybe 9 to 5 because of the offices that we work in and the institutions we work for. So then I only mention that just because I, like you, am also looking for ways to better understand how we can all do better work. And that's one way then also that has been super meaningful to me, and I know for many other people on this call.
And Anand has said he's willing to speak to his experience. So if you're willing to pop on, that'd be great.
Hey, I just wanted to just sort of emphasize how valuable this session has been, and also to all the guidance that I've gotten from both you and the cards team and all the individuals who are the community members who participated in this. I think, just looking at this is from a research standpoint or perspective, is that I've learned so much as somebody who moved to Wisconsin about 2.5 years ago or so, and to learn a little bit more about the climate and the environment and what people are sort of experiencing. The cards resources, I've learned so much from them, not just from a research perspective in terms of the proposals that I'm developing and setting up, but also if you really want things to be sort of successful in terms of the research innovations or clinical innovations that you're doing, I found them to have incredibly thoughtful advice and guidance and suggestions. We were actually just talking earlier with Kat, and just talking about how valuable the suggestions we got from them. And I mean, this is literally a roadmap that I'm going to take back to my to the breast center colleagues for how we can make sure that we can prioritize all these different innovations and suggestions that they have in terms of our breast center clinical operations. And so I just found this experience to be amazing. And I'm not even sure that we're just talking like in terms of setting up meetings. Like I think I'm just looking forward to the opportunity just to connect with the group again and just share time. They have some really talented people that are hoping that some chefs and people who have catering businesses as well too. So I'll put in a shameless plug for some of the people who have businesses and can produce some very nice, delicious foods as well. As well, so they catered the last meeting. So I'm looking forward to this session once again, and just having the opportunity to connect with them on a regular basis as well too. Just not just in terms of research, but just in terms of having to meet with a really good group of people and just connect regularly. So I commend all of you for setting all this stuff up and just having the opportunity to learn from the cards participants and the team as well.
Let's take one more question. Thank you so much on that was great. There's one more question. How does a typical cards meeting differ from discussion with a CAB? I'm sure there are significant differences. Whoever wants to take it.
Yeah, so CABs are often formed with a specific lens and recruited for their specific knowledge in an area. So a CAB to advise on. For example, the Carbone Cancer Center has several CABs, and they're often people who have had cancer journeys themselves or have family members with experience with cancer. Cards are unique in that they're recruited broadly, not for any specific life experience, other than they were recruited because they are connected with and use services of neighborhood centers. So the Goodman Center and Lucier Center. Their experiences are often in neighborhoods that have been under-resourced, in programs that may be under-resourced, but oftentimes it's this connection to the community center and the group and the people there that brings them together. They offer a lens to a huge, broad range of projects and studies and topics. So that's the primary difference. And also many CABs are set up to receive information as much as to give information. And a cards meeting has like 15 minutes of setting the stage that they learn about what you're asking, but then 90 minutes or of the 90 minutes, an hour of it is just listening. So it's very feedback centric, which sometimes CABs are not. Different CABs work in different ways, but it's also not condition specific. It's broad and works with a variety of issues. Hope that answered the question.
Thank you so much to Kat, to Shanice, to Shannon. A great presentation. Really appreciate this, and a good reminder for how we should be doing our research and why. So I'm going to put in a reminder also. There's a link in the chat for the evaluation. We would like to make sure we get your evaluation, and helps us design better programs. So thank you, and we will see you all in a month.
Thank you all. Thank you, Shanice. Nice to see you. Take care.
Thanks.
Thanks so much. It's
All
nice to see
right.
you all. Thanks for the work you do.
Thank you.
Okay. Thanks, Shanice. Thanks, Shannon.